Okay, it's recording. So this is our IPER 3 case video. I'm going to go ahead and start from the pharmacy aspect of this case. We had a patient named Maria J that came in and had an order for an IV analgesic. Upon noticing her chart, she has severe nausea with the medication. So the pharmacist calls the physician and the nurse and verifies that the patient's not really Maria J, but Maricela H. As a pharmacist, the first thing I would do, I would try to practice pharmacy in the most ethical and lawful way I can. So once I found out that she's using a different name, I wouldn't be able to dispense the analgesic under Maria J. For a couple reasons. Mainly, it's an insurance fraud. It's illegal as well to dispense a narcotic under somebody else's name in Texas. So first, in order to treat the patient, I would make her a new account and process the medication for the analgesic under her real name of Maricela H. Um, since her chart's the exact same, I would ask her if she has nausea to this medication. If she does, I would just explain to her really that narcotics cause nausea. It's like the most common side effect. So at this point, she'd still be able to take it since it's just nausea. Um, I would probably ask the physician or the nurse if we could prescribe Zofran with this medication since they don't interact, and then it would help ease her nausea. In terms of that, that's how I would attempt to solve this case. I'm good.
So I'll go next. So as a nurse here, I think big thing is like at the end of the day, we still have a duty to the patient, whether it's whatever name she's going by. I think you're still gonna treat him the same, and he's still a human being, gonna do our best, obviously provide care for them. Oh, sorry. One thing I did notice, they were talking about how she did state that her real records were already under her real name, so she does have, I guess, a clinical record that we can access. So I think like the biggest thing is to make sure we obviously communicate that with the whole team that say, hey, this isn't, this is her real name. That way we can kind of like what Josh said, get a new chart and kind of get going on that. Because like one thing scenario I was kind of thinking about that where this would kind of stump me up is like we're doing like med admin for like we always do like tell me your name, date of birth, or to make sure like to avoid med errors and stuff like that. So like if she isn't able to like or she states the wrong name, that would definitely stump us up there. It's into like, okay, we can't administer this. So that's like I just think the biggest thing is communicating that like the whole healthcare team, has to know that obviously real name is, and then we could get a new chart and kind of go from there. And then I would say last like with the COVID aspect of it, she was saying how, they had heard her saying that she was still gonna go to work. And I think like as a nurse, what that comes down to for us is more just like patient education. I mean, tell her to wear a mask, maybe like is she vaccinated, whatever it may be, but kind of give her the most information we can so she can make an informed decision. But at the end of the day, I mean, it is ultimately her decision. We can't, force her to not go to work. So that part of it, that's still up to her.
We could also kind of communicate together and try to maybe they have COVID medication now, like Paxlovid, so we could probably try to see like work together and maybe if she's going back to work, we might as well give her medication to help reduce the symptoms and chance of it spreading as well with additional
Yeah, that's very true. I
medication.
didn't think about that.
I agree with everything that's been said. I think my biggest concern, or not really a concern, but I think my biggest thing would be making sure everyone's functioning within the same chart, because I think there's a lot of things going on with her being undocumented, her having COVID, and et cetera. And insurance fraud is a thing. So I think it would just be it's kind of a really sticky situation, I guess, but it would get even worse if everyone's not on the same chart. I guess just because if you have insurance on one chart and you don't have insurance on the other chart, it kind of comes to a point of what can be done and what can't be done. Just because different things can interact, different medications need to be dispensed, or if she needs a procedure or just any complications that could come up, especially with COVID. If she went back to work and then she needed to come back and there was somebody else on, how do you know which chart to go to for history and etc.?
In the case of Maricela, or going by the name of Maria, I feel like the healthcare provider should educate her in the fact that she's able to receive the same quality of care regardless of her legal status, and inform her of the possible legal repercussions of using her cousin's health insurance information. She should also be informed that the doctors cannot provide her with the best care possible if she's not providing the adequate medical history. Since they already have a medical history attached to her consent information. It's possible that Maricela is not providing the correct information due to the fear of being deported. But if, as healthcare providers, we educate her that we are able to give her what the care that she needs, she might be able to feel more comfortable and not use her cousin's information. And that will, let us use a new chart without confusing everyone else that might also need information from her chart.
All right, and then going back, kind of talking about EMTALA and some of the laws associated with this, I think based on this scenario, EMTALA mandates were upheld in that the patient came to the ER, they were screened and stabilized, and that happened before really any of the insurance or identity confusion happened. And that's kind of the main thing of like making sure the patient is stabilized regardless of insurance status. And then to kind of summarize the points that we've talked about so far, in terms of the care that she gets after getting stabilized, I think we kind of touched on ADA principle of justice applying in that we should be treating all patients regardless of their immigration status. And from what I researched, healthcare professionals don't have any obligation or responsibility to report anything to federal immigration authorities. So kind of like Myra was saying, reassuring the patient that like her being undocumented doesn't really mean anything in terms of consequences for her. We just want to make sure that she's well taken care of. And then there are definitely some issues that arise from using Maria's identity with the step with ROGAM and IB analgesic. And I think we kind of all agree that care should not be continuing under someone else's name. And I think the principle of non-maleficence kind of comes in there because you don't want to be, I think kind of like everyone has mentioned, you don't want to be looking at information that relates to someone else and changing the way you treat Maricela based on Maria's health history, or even in the future, if something related to Maricela gets documented under Maria's history, that could be potentially doing harm to Maria in the future. So definitely not a good idea to continue using Maria's chart. And then from there, I kind of felt like there were two main options. I'm thinking if she were to continue getting care at the hospital without without Maria's insurance, that would probably be a bit of a financial burden on her. So then I was kind of looking to the next part of EMTALA, which states that if definitive treatment can't be provided after stabilization, an appropriate transfer may take place to another facility with adequate capabilities. So essentially, maybe it might be in the patient's best interest to for us to work with the free clinic and make sure that she gets the care she needs there. That way it's still safe, we still have the right medical history, but we're also avoiding the financial burden. But then the other option was that I felt like there might be something out there for her to get some kind of coverage. And it seems like Texas authorized a CHIP perinatal program in 2005, which would actually provide prenatal visits and limited postpartum care to both lawfully present and undocumented immigrant mothers. So that might be a way for us to continue to provide her care, keeping it safe, but also keeping it affordable for her.